On the increase, suicide in the medical profession. People are so depressed there, some are taking their lives. Now, doctors are a lot more likely to commit suicide than the general population. They're also the least likely to seek help. What leads medical professionals to take their own lives? This is the answer that former doctor Yumna Musa gave 2 years ago.
Humiliating and degrading lower-ranking doctors is a big part of medical education. Medicine is a military hierarchy. Juniors are constantly told, this is what your seniors went through, and we must just do our time and get it over with. Some think this just obey orders approach is the best way to deal with emergencies, or an overwhelming war against poverty and disease. Those with influence must deal with the systematic culture of abuse in medicine.
With me, Professor Bernard Janse van Rensburg, Chairperson of the SAMA Academic Doctors Association, or ADASA, and Sarah Davids, Project Manager at Health Systems Trust. Good to have you both with me here in the studio. Sarah Davids, is that what's behind what we're seeing in the medical profession? I mean, is it that sort of level of bullying?
Not just in the medical profession. I think it ranges throughout all disciplines. So whether you're talking about nurses, not just the doctors. I think we're just lucky that the doctors highlighted this. But the stress is also felt with community health workers that we've now entered into the health system. We've also got clinical associates. So in a way, the system, we're entering people into a system that is very complex and very hierarchical and does cause stress on individuals at all levels.
Okay, tell us more about the sort of stress that these individuals go to and how it differs depending where you end up.
Most definitely, I can strongly agree with the background information that's been provided. And it is true that it's also our junior colleagues and students that seems to be definitely on the receiving end of this in particular. At the same time, though, I think this is that very same group, the younger group, that started to verbalize this. If we think about the past months in the media, the very prominent death of Professor Mayosi from UCT, but also just different universities where students have actually also committed suicide successfully. It's almost a bit of a groundswell that has been developed that is difficult to ignore and not attend to anymore. So I think it's encouraging that different groups, our own group, the Society of Psychiatrists, and the Society of Anesthesiologists as well, have independently almost started to realize and started to communicate that there's need to address.
And why do you think it's got so bad? Has it got worse, or do we just know more about it? And how come it's been allowed to happen?
I think it's part of the system to a large extent, and the health system, and looking at the day-to-day lives of nurses. So we've got a quadruple burden of disease. So we've got HIV/AIDS, we've got TB, we've got all the chronic diseases, and what we haven't made a space for, ideally, within the government system is also space for nurses to debrief, spaces for community health workers to talk about the trauma, the difficulties, the challenge that they see on a day-to-day basis. And as that piles up, and be dealing with people that are working in communities with high stress, challenges, often single-headed houses, women, female-headed households. So all of the socioeconomic factors contribute to the challenges, and they have to show up for work, being good when actually inside they're not feeling good. And a lot of the time they're seen as machines and cogs in the system, as opposed to human beings who also have their own feelings and also need to develop that level of resilience in order to cope within a very challenging health system.
And we're radically understaffed as well, don't we? I mean, facilities have closed down, the money's not there. I guess that adds to the stress as well.
Most definitely. As Sarah's been saying, threefold components: the way that we practice, the infrastructure, the logistics around that, but then also the personal relationships, I would say, in the place. And I think the third component then there is one's own resources, and when it's starting to run out, if one thinks about burnout and the components that lead to that, there is always a work-related interpersonal scenario, whether it is a hierarchical aspect or just the overload, the case burden, the ongoing, relentless process of having to keep caring. I think those are really across the board, and very true that healthcare workers across the spectrum, medical, nursing,
and what's
and
interesting
others.
is that they don't self-medicate, do they? They don't really cry for help. I mean, what is it? Is it because they feel that they should be offering this, that it's hard to seek help for
I
themselves?
think they do self-medicate. We find a lot of
In the wrong way.
alcohol abuse, we find drug usage, we find all of those normal coping mechanisms, because health workers, after all, are people. What is also fascinating is that in none of the Nguni languages do we actually have a word for depression.
It's interesting.
And so whilst the diagnosis might happen within a medical setup, it's very difficult, and depression doesn't only affect the individual, it affects the family, it affects the community, and it affects the actual service delivery. So those are all challenging things that we're having to face. And through
the service delivery, I mean, that's an issue, obviously. I mean, you've got to feel for those in the medical profession who are suffering, but the knock-on effect is, I should imagine, detrimental and possibly fatal sometimes.
That's very true, and I think that is where the discussions around how does this affect one's productivity, capacity to manage and cope, professionalism and so forth, capacity to make more mistakes, judgment errors and that type of scenario. So burnout, again, the typical factors creeping in there includes a bit of a depersonalization and dissociation from the situation, and most definitely a lower level of performance and activity.
Now, you work closely with those affected.
Yes, so we've been running a program called Wellness for Effective Leadership. And a lot of that is getting people back to understanding, starting from the self, learning about emotional resilience. But a lot of the work that we do is we intentionally work with small groups of people, teams within clinics, hospitals throughout the range. And what we do is often there's an intentional way to deal with historical or trauma that has been buried deeply, because often that blocks the ability to develop and accept stress and coping with stress mechanisms and resilience. And a lot of it is also emotional intelligence, because they were schooled at a professional level, in a societal level, and in a family to cope with things differently, where you keep quiet. So whether it's abuse or whether it's a financial abuse, emotional abuse, all of those issues come up when we deal with people, and eventually they're able to develop a sense of agency and then take charge within the space where they're working. And we've had people from 2009 that we've worked with, and often those people come back and say, I've tried everything else, please come and help. Nothing else works.
And I suppose that's important, is feeling that you are in control, in charge, you can reclaim your power and confront those who are abusing in a sort of military-style fashion.
Most definitely. And I think another factor perhaps to add to that is the sense of isolation and loneliness. And I think that is a space that one can understand can easily lead to some desperation and a few options out. And I think the efforts to try and communicate about that, Sarah talked about the resilience, culture of wellness, to create an environment in which there is a capacity and a willingness, a freedom, address the stigma, self-stigma, professional stigma around having to talk and address and engage with these issues as health professionals.
And I should imagine you must be worried of a skills drain when people know that it's so hard working here, so they might go somewhere else. I mean, it's got to be turned around and turned around pretty soon.
Yes, it's skills drain, but it's also also people are exhausted again from a financial aspect. We've also done other studies where we found a lot of the nurses moonlight, so they work in public facilities at some part of the day, and on their days off they work in private facilities. So inevitably our one health system that has got two components of public and private is strained either way.
What would you like to see happen now?
I think from our side, this growing process, hopefully, of being open, starting to engage, following our younger colleagues' example, really, they have led us in this, to be honest, that we could, as a professional, become more communicative, more engaging, more supportive, peer supportive
So I don't think the public knows enough, do they?
So not to so-called cause alarm in that sense, but I think the profession itself may be very well situated to be involved in the intervention and the reaching out and opening up the space of a different culture and a different view of dealing with professionalism.
Can you give us a percentage, a sense of what sort of numbers we're looking at here?
Ooh, that's it. Nationally, it's a big ask because nationally we do not monitor or tick those numbers. So what we've done across various disciplines is do surveys. So each discipline-specific profession knows there's a risk of stress and burnout. We've even found that in places like in palliative care, we have those nurses are actually more resilient than the rest of Barra Hospital, for instance. And the reason is because they know that they're working in an area that's very draining, so they accommodate and they make space for people to engage. And I think that's what's lacking, both in our student, throughout our national university medical curriculum. There's no safe space for students to talk about the issues, process those issues, and help them to develop into more resilient professionals, because there's no way that they can also care. In order to care for others, you have to learn to care for yourself. And that's centrally what we teach, is go back to yourself in order to deliver the quality health service that you can, because you can then care for others.
Well, thank you for talking us through it. I mean, we might not know the numbers, but it's way too high. Professor Bernard Jansen van Rensburg and Sarah Davids, thank you.
Thank you.
International weather coming up next, and in a flagrant violation of international law, the United States has recognized Israel's sovereignty over the Golan Heights. What are the political implications of this move, and who does it benefit?